Hey everybody, it's David, host of Highway to Health podcast series, and we've got a fun one for you. Today we're at Billy Bob's. It is the historic venue here in Fort Worth, Texas, where some of the best to ever do it have been on the same stage. Willie Whalen, George Strait, Garth Brooks, you name it, they've been here. And I'm honored to be on the same stage that they shared. You know, today we're gonna talk about not only the history of Billy Bob's in Fort Worth, but how DFW has become this hub for healthcare innovation, strategy. You have some of the best providers, the best solutions, the best partners in healthcare right here in DFW. And when you look back at the late 19th century, Fort Worth was the mecca for cattle and the cattle trade business. And just down the road at the stockyards here in Fort Worth, that's where a lot of business took place. Fast forward to today, and healthcare is the new hub in DFW. And we're gonna talk to some amazing leaders in the healthcare industry today. We're gonna talk about different areas of the healthcare industry and understand a little bit better why DFW is becoming the destination for some of the best businesses, the best providers, the best professionals in the healthcare world today. Right now, I'm excited to share the stage with Kelly Strong, who's been in healthcare for over 20 years, 24 years.
24 years, yeah.
Right here in DFW.
Yeah.
So you've seen this area grow.
Huge. I've seen huge growth in DFW and in the healthcare sector. I've seen a lot of growth. New companies coming in, new hospitals being built, and urgent cares everywhere.
Urgent cares everywhere.
Yeah.
And we depend on those urgent cares quite a bit, especially with a bunch of kids running around. But why has DFW become what it has become over the last 20 years here in the healthcare space?
Well, I think, in Texas, you have the wide open spaces, as everyone knows, flat land. Used to be for cattle, as we talked about. So that land still exists, and now it's not so much cattle, it's turning into people and housing. And the population growth has been substantial in Dallas over the last probably 20 years. Really, in the last 5 years, it's been exponential growth in the amount of people and companies coming. So not just in healthcare, but you have, Toyota and some of the larger companies that are relocating to the Dallas area because our economy is good. We have good economy here in Texas, and our taxes are nice, and companies like that.
It's welcoming.
Yeah, that's real welcoming. Yeah, very welcoming. Sometimes too welcoming when I'm driving this morning.
Yeah.
But I think for healthcare, the reason it is again, because of the growth in population, where the people are, you need services,
Yep.
And healthcare revolves around the patient, regardless of what sector you're in. If you're a doctor or if you're a technical person, it still always relates back to that one individual patient. More people, more healthcare.
More people, more patients.
More people, more patients, yes.
And more need.
Yes.
And there's plenty of need here because of the population growth. Tell us a little bit about the role that you've played in the healthcare industry here in DFW over the last 24 years.
Yeah, so I started when I was 12 in healthcare, so I've been in it about 24 years now, as a bill collector. So I started at the very bottom, and this is an attempt to collect a debt. Any information obtained can be used for that purpose, and may I have your birthday, please? That always made for a great start to a conversation. So I learned my way through understanding insurance and how claims process and the patient impact on it. And my passion has always lied in the patient impact because of starting in that fashion.
Sure.
I know what, if you don't do it right, what happens, and it's not necessarily just to the facility or the provider's bottom line, it's to the patient. The individual patient is impacted by that.
Yeah.
So I've made a career out of making sure to protect patients as best I can. I've been working with organizations, so I've worked all the way up into senior leadership for providers. I've worked for several different tech companies. From the vendor side, and done consulting, many hospitals I've been in and seen lots and lots of things. So some kind of scary, some humorous, and some like, wow, why didn't I think of that,
Right.
So I have a broad view, I guess, of healthcare and how organizations work from both the provider side and from the vendor side. So
Yeah, you've got a well-rounded amount of experience from, obviously we're all patients, so you've seen it from that angle. You've seen it from the solution side. That's where you and I met.
Yep.
And then you've seen it from the provider side. So you have this unique perspective because you understand how the different areas or the different communities of healthcare are impacted when things go well, but also when things go poorly.
Yeah.
And some of, our experiences together, I think paint a pretty clear picture of when things go well and when things don't go well. Yeah. What that means to the provider, what that means to the patient. And I want you to share some of those stories today.
Yeah.
I think through these stories, our community will learn a little bit, but they'll also understand that when things don't go well, what that means for the patient, what that could mean, even legally for the provider.
Sure.
And so I'm going to throw out some terms, revenue cycle terms at you, and I want you to share your favorite story.
Okay, no pressure, no pressure.
No pressure.
Okay, we'll do it.
We'll keep the innocent unnamed.
Yes, we won't name names or decades.
But, I like to start, probably the biggest topic in revenue cycle when I started 15 years ago to now has always been denials.
Yeah.
It's an ever-changing game, ever-evolving game. The balances of these games are unfair at times. But let's start with denial reason. What's the most humorous, informational or educational story that you've seen and experienced around denial reasons that a provider sees?
Yeah, I mean, I think the reasons become pretty standard. I think why they deny is pretty erroneous. Requests for medical records for a broken arm. Clearly their arm is broken, Medical records on a standard colonoscopy, Yeah. And the reason the insurances do that is to make sure, number one, you're compliant, right? Are you documenting the correct things that you need to document? So that's part of the reason. The second reason, I think, is because they can. There's nothing that prevents the insurance from requesting that from you.
Sure.
So it's a way to stall, if you will, but it's also a way for them to programmatically or systematically make sure that their providers that they're partnered with are playing by the rules. Is that stuff documented, and can you show it? So I think it's kind of funny when they do send medical record requests, for some standard things. It's a huge burden upon the provider, to come and pull those records. You have to manually pull them for the most part. And we can talk about some AI and different ways that you can, handle those rejections and quantify them, I think is really important. Another one is timely filing. It's almost laughable, and you and I laughed a little earlier about timely filing. How does it even happen?
Right, right.
You have your EHR that's sending the thing over to the clearinghouse, and it should just go straight out,
Yeah.
But what we find, and this is where the consulting piece comes in and you're really advocating for the patient, is that our technologies aren't as integrated as we'd like them to be. And a lot of times providers will connect their technologies. It goes through this implementation phase, and then we don't talk about it again.
Right.
It's just doing its thing.
Set it and forget it.
Yeah, set it and forget it, Like, we don't need to change the oil until the car tells us, right? And that's kind of become the world with technology and healthcare, I think. It's a fast-growing industry.
Yeah.
It's definitely, the denial side is really, I think, where a lot of vendors come in and work with customers and providers to help quantify, get data metrics around that and all of those pieces, but really understanding what is the root cause of the denial, And going back to my collection days, I didn't know any of the technology stuff was there. I had no clue what an 835 was and that I had loops and segments and all these pieces, So I'm just going at it of like, well, I don't know, your insurance requested medical records, so you need to send them, and trying to figure out why is that happening, As I progressed in my career, I quickly started figuring out how does the technology and the routing of claims and that information create your denials. So I think really tying it back to understanding the fundamental of the denial. Where is it coming from? So I think that's important.
And every time one of these denials comes back, and every provider deals with this, every clearinghouse deals with this, every time a denial comes back, it means somebody has to touch that claim. Somebody has to do the work to figure out and solve the problem.
Yeah.
And then down the line, if the denial comes back, we don't work it efficiently or correctly, there's an impact to the patient. And we're going to talk about, a personal story that you have on the impact it's made to a patient that you're familiar with. But before we get there, let's talk about, you have experience in a clearinghouse. That's where we met.
Yeah.
There's a denial, and there's also rejections.
Correct.
Start with the difference between the two, and then share your favorite story when it comes to a single rejection or what we might call a batch rejection.
Sure. Yeah. So denials are when a claim denies, telling you it's after it's adjudicated. I think, and that's the key, right? Is understanding once you get a remit back, an explanation of benefits, or in the technical, we'll refer to that as an 835, which is the transaction set, right? So once that denial comes back from the insurance company, it's already been adjudicated. The insurance has looked at that claim. They've received it. It's in their adjudication system. They're saying, nah, we're not paying you, right?
Right.
They're saying no.
Yep.
Okay. And then you have what we call front-end rejections or rejections, which is a lot of times confused with a denial.
Yep.
Providers will talk about that kind of interchangeably. They are not. They're two totally different things, measured different ways, reported differently, and come from different resources, right? A rejection is typically coming prior to being entered into the insurance's adjudication system. So these are going to be things like you have to have a 5-digit zip code, or your provider's not credentialed, which is funny. So,
we'll talk about that too.
You don't fix that by just saying Dr. Smith did it on Tuesday and Dr. David did it on Wednesday. We don't do that, although I've seen that. You can't do it. But a rejection, again, is going to be pre-adjudication, meaning your timely filing clock and stuff is still ticking. So as we were laughing, the excuse for timely filing, could it be that you're not monitoring your rejections correctly? So I've been in organizations, large organizations, big ones, well, they got commercials and they got banners in the airport, and they don't monitor their rejections and wondering why they have, this DNF fee or all this outstanding account AR sitting on the books. And it's like, well, here's rock number one, let's start there. And things, again, like I said, as simple as, not having a 5-digit zip code.
Could reject the entire batch of claims.
Entire batch of claims, yeah.
Which could be thousands of claims.
Thousands of claims.
Millions of dollars.
Yeah, you can have one little tilde in there on one claim that somebody typed a note or something that got into that 837 file, which is the technical transaction that sends to the insurance, and that can throw the whole claim off. So making sure that you're editing appropriately and using your technology up front to make sure that that file is compliant is key to success. Right? And talking about clean claims and all of those things to understand, when we talk about clean claim, it's not just getting it paid, it's getting it there. There's two phases,
Yeah.
Your rejection rate and then your did it pay rate,
The rejection to me is like not letting your neighbor in your front door.
Yeah.
Hey, your shoes are too muddy.
Right.
You can't come in.
Yeah.
The denial is kicking them out the back door. And hey, you've had too much to drink, maybe.
That's right. Yeah, you gotta go. You've been at Billy Bob's too long. Time for you to get out. Yes.
But at the end of the day, it has an impact on the cash flow, the reimbursement, the margin that our providers work with.
It does.
And so understanding the difference, because oftentimes the rejection rate is pretty black, or the rejection reason is pretty black and white. It just takes some digging and some understanding of the format to get it fixed and to get in the front door. Just take your shoes off. You're welcome in.
Yep.
The denials seem to be a little bit more complex and confusing to fix, maybe even time consuming to fix and to get that claim paid.
It is, yeah. And they all have, again, your timely filing starts to play in. And a lot of providers, don't focus on timely filing, and it's important when you look at the amount of rejections that you have for that reason. Some providers do it very well and some don't. That could be your top rejection reason. And if it is, that's an easy fix, but you have to go back to the basics. And I would say, it's either process, the people at the front end didn't capture the information correctly,
Which is a hard job.
Yeah. Well, and I look at it as authorizations too. Personally, I've had, physical therapy that was done, supposed to be inpatient physical therapy is what they authorized. Well, I'm not going inpatient for physical therapy. Clearly, it's outpatient.
Right.
You're going, every day or whatever.
Sure.
Well, when the claim gets billed and they bill it with the procedure code for the outpatient and the authorization was done for inpatient, my claim's denied. And here I'm sitting there, $20,000 billed to me personally, right? Because again, the patient is the responsibility, the onus is on the patient. Yep. The providers try and help because they want that reimbursement. At the end of the day, it's the patient's responsibility for that.
Yeah, that bill comes in the mail.
Yeah.
And it's due.
Yeah. And I know working in healthcare and to the extent I work in it, I'm like, that's not right. If you have patient bills that are over $5,000 or $10,000, big red flags should be going off in your organization. That should not be flowing to collections, And in that case, it took me, because it went, into collections, and I'm telling them, I don't owe this. You authorized the wrong code. All that had to be done was a retro authorization, but the customer service reps that I was able to get to as a patient had no clue what I was talking about. So that bill went unpaid. right? By the time we got it fixed, I had to call the CFO of the hospital in order to get that fixed.
And if you didn't know healthcare and revenue cycle like you do, you'd be looking at ways to pay this $20,000 bill.
That's right. Yeah.
And that's the impact to the patient that
It's huge.
I know providers understand to an extent, and I know patients understand to an extent. Man, that can take a huge financial toll. You talk about financial toxicity to an individual, and that's what we want to avoid. Right. And then, because then you start talking about experience, and the patient's always going to blame the provider, even though the payer plays a part in this. But patient experience negatively reflects on the provider, and they may start looking for different places to take their business, or they may avoid the healthcare system in general because they don't think they can afford it. And so then the dominoes start falling, and the population health of this community really takes a downturn, and that's what we don't want. And that's how important revenue cycle is. I want to talk about the next thing here. And the next one is, we're going to talk about AI and automation, because that's a big part of revenue cycle.
Stuff, yeah.
And that's what we need.
The magic.
That's what we need.
Bippity boppity whoa.
Yeah, the magic, yeah. And we need that to start addressing some of these staffing shortages that we're all experiencing. But automation and AI comes with risk. What's your favorite automation story gone wrong?
Yeah, so automation stories gone wrong. I mean, I have quite a few. Again, the one we talked about earlier, we don't know who the...
Share it, because I was there for this, and I still tell the story.
So this is a long time ago. So I think it was a providing physician, I guess it was. And they had worked with their vendor who, worked in their claims and whatnot, and put in a routine, which is basically AI automation, right? That said, if the data service is on an odd number or, Monday or whatever the logic was they chose, then plug in Dr. Smith,
Whether Dr. Smith was there
Whether Dr. Smith was there or not, because for some reason there was a disconnect in their EHR, I guess, that wasn't transferring the physician that actually saw the patient. So they were just making a list of whoever was credentialed and just, pick one of them that works in that ER. This one usually works on Wednesdays, should be fine. And they put that in, and I'm sure the month or two when they put it in, those doctors were pretty consistent with their schedule, but as all of us know in healthcare, that's not how it is. Those providers are moving around all the time. 2 years later, when we're reviewing their logic, lo and behold, those aren't the providers seeing those patients,
Yeah.
So, and I think that brings up a good point, is when you put in this type of, logic and information, you have to audit that. And if you don't have your operational leaders, not your technical people, because technically that routine was running as it was supposed to.
Claims were going out.
Good, paid all day, we're eating, But if you don't have your operational leaders understand enough about technology and review what the automation is doing or what the systems are doing on a regular basis, probably twice a year. And it should be, 4 or 5 days where they're just looking at that logic, making sure the rules still applied, working with your compliance departments. You're not doing yourself any favors. And as AI starts to grow in healthcare, I'm very passionate about that because it does impact the patient. In those cases, the insurance company can request medical records, through their erroneous denials, find out that wasn't the real doctor, audit you, and now we have a big problem on the hand. And at the end of the day, that goes back to the patient.
Yeah.
The patient would get billed. They retract that money. Now all of a sudden you have an auto collection process going. The patient's getting the bill for, services that were rendered that really they shouldn't be paid.
Yeah, because rightfully so in this case.
Yeah.
The insurance company is saying, I'm not paying that. That's not right. That's not accurate. It's not compliant. I'm not paying that, which is what they should do.
Right.
But, and look, automation, it's going to have to be a big part of our path forward in revenue cycle. But we have to be aware of these risks. And the only way of doing that is getting the people who know the business, know the industry, involved in these conversations. You mentioned it earlier. Our providers are relying on a large tech stack these days. And those technologies are disparate, which require integration. And every time we connect those, every time we automate a step, there's risk involved, there's errors that could happen, and it can't be a set it and forget it type of process. It's got to be consistently reviewed so that the providers stay safe, stay compliant, the insurance pays what they need to pay, and the patient can get the care, the access to the care that we all need.
Yeah, and integration is huge. So I'll tell you a story. It kind of is a sad story, really. It turned out to be okay, but it was a pretty big patient impact, on the way things integrate. So this patient name was Billy, obviously, Billy Bob's. We're going to go with Billy.
Not Billy Bob, but somebody
yeah, Billy
else.
Bob, Billy Bob. So he had a heart attack, and went into an emergency care center, kind of lived in a rural area, went into emergency care center, and they stabilized him. Well, now he's got to go over to a real hospital with cardiac center, So to get him stabilized and everything, they called the insurance. Hey, we got your patient in here, all of that. Documented in the EHR, all of the things that needed to be done. And then they transported that patient to one of their own in-network or their network hospital facilities, right? And admitted him as an inpatient, okay? He gets the services, they put the stents in, whatever they do, right? He's good, still alive, kicking today, making furniture and all the things, like all is well, right? But about 6 months later, he gets a bill, $28,000 he got billed for that inpatient stay, And again, it's a situation of where you get a bill as a patient, you're in the hospital, we know healthcare's expensive. He didn't question it.
And he's a man of means.
Gosh, I guess I'll have to take out the retirement account, pay that bill, So I got wind of it, this huge bill, and, my friend was talking about, and I'm like, let me look at this bill.
You're a good friend. You're a good friend to have.
Right, So I start to looking at it, and I, get on the phone with the insurance, and they tell me it was denied for authorization, right? And because of the way his policy was written, the denial for authorization rolls to patient responsibility. So in that denial that was received from the insurance, and again, here's your automation coming in the patient accounting system, it said PR, 50, medical necessity or whatever the reason code was, $28,000 we're not going to pay. Because the insurance said if it's not authorized, then what the allowed amount is billed to the patient. Okay? So what happens? Nobody reviews that. We got some money from the insurance, it's paid. Right. There was a contractual, and there's a PR code in the 835 that says he owes it. Not one person was like, why would a person with good insurance pay $28,000?
Yep.
So when what had happened, see what happened was, what they should have done, is when it transferred from the ER, right, even though it was the same organization, they used two different patient accounting systems. So you have patient accounting system one over here that has all that patient information. That was not transferred. That authorization number that was notated over here was not transferred into the hospitals, the inpatient stay side, right? So when they built the claim on that little box that says authorization number, they had it.
Yep.
But it didn't connect over, and that's one patient. Right. How many times did that happen to that same organization where Billy just went and pulled his 401k and be like, we're just going to have to work 3 more years,
Well, first of all, I'm glad he's safe and healthy.
Yeah.
And I'm glad he had a friend like you to help work through it. But you said it. This is one example. But at the beginning of this show, we talked about the growing population that are all patients going into these providers that, have a huge footprint in this community. Billy is one of many. Yeah. And he may not be the smallest, but he may not be the biggest example of how these things can happen, impact the cash flow of a provider, and impact the well-being, financial well-being of our patients.
Correct.
And that's the scary part. That's the part that needs to be addressed. And that's why you've seen so many technology companies and partner solutions come to the DFW area, because the providers that are here have a growing population, patient population, which means growing complexities and challenges, and they need help. And that's why we've seen DFW grow the way we have. With all of these changes, with all of these challenges, how important is it? Because the revenue cycle is a long string. There's so many handoffs from when we take that patient's information, the way to the end where we're collecting the cash from the insurance or the patient. There's so many handoffs. Every handoff could have an error. How important is the education of our billers, of our reps, of our entire organization on the impact that this could have to our business and our people?
Yeah, I think it's huge. I mean, I think everyone down to front-end registration, nurses, doctors, everyone in the organization needs to understand the basis of technology. They need to understand how technology works. I'm not saying be an expert. I'm not saying they have to be Kellys and they have to know everything and loops and segments and how it all connects, or even remember that what an 835 is an EOB and an 837 is a UB1500, right? They don't need to know it to that level.
It would take 24 years for them to know it to that
level.
Well,
yeah, 24 and a lot of crazy, But I think really understanding it, so when they're doing their jobs, they know it exists. And I think that's the thing. Me coming from back in my collection days, this is an attempt to collect a debt. How much money as a collector, if I understood that technology piece even existed, I would have been more, effective at my job as a collector, resolving those balances, resolving those patient accounts, trying to get, in Billy's situation, $20,000 from Billy, that is heartbreaking and wrenching, where all it took was a call to the provider, say, oh, can I get a retro auth? Here's the authorization number. Bippity bop, put it in the insurance computer, reprocess the claim, and they paid the rest of the claim. He ended up owing $1,200.
And not giving a guy who just had a heart attack
another one. Yeah, that's not how we want to.
And I'm not trying to make light of it.
Yeah, it's true. I mean, it is, and Billy and I joked about that. Like, here's heart attack number 2. They're trying to get you back, I mean, you don't want to do it that way.
No, you don't.
So, I mean, I think that that is a big, huge piece of it, is training your staff at every level. We do a good job, I think, at training them on what buttons to push and F this key and you have to document here. We do a really good job at user application, right? But I think most health systems I go into fail at what happens after that. What's behind the scenes, And again, it's a simple course I think everyone should take once a year. That's just like, don't forget, there's all these magical wands that aren't really magical in healthcare.
Right.
And the department leaders, director, manager level, need to be very versed in what automation is going on within their system that they have control over. Again, back to the zip code thing. Are we plugging a zip code and then I change my billing office? We close that hospital and move another one? Now that zip code is wrong. That address that has been automatically plugging for years and years is now not working. So now I'm seeing rejections for wrong address. I'm seeing denials from the insurance for, invalid information. Patients not insured, that kind of stuff, because we're plugging in programmatically things that worked last year
right.
that don't work today, Yep. And, you've seen it, I've seen it, and many of the vendor companies and the providers that I've worked with. Technology is great, but you have to manage your vendor. You have to own what you're asking the vendor to do. The vendor's not responsible for you plug Dr. David on Tuesday, They're not going to get that fine. They're not the ones putting on the orange jumper.
How do you look in orange? Yeah.
Yeah, how do you look in orange? Yeah. And I think, again, a lot of times we lose sight of it. And I think that organizations should have, departments really and individuals that are responsible for that vendor management. And a lot of times what I see is we have, our IT department, they don't do operations. Again, the routines, it's working.
It works. The logic's right.
What it was supposed to do.
Yeah.
But they don't know the operational know-how to know it shouldn't be doing that anymore. Yep. We don't plug that modifier anymore.
Yep. Which I think speaks to the importance of, these partners and these providers really doubling down on the education piece. I had a provider in California tell me, if I could get my registration folks to understand that what they put on that claim is going to stay on that claim all the way through the cycle and is going to be what shows up at the insurance company and the impact that it could have on the entire ecosystem, they would be more focused on that information at that point. If we could fix it up there, it would help us all along the way. And back then, I mean, this was 10 years ago, he was needing a way to educate, engage, even inspire those front-end registration people to really be intentional with the data that they're collecting and inputting, because it makes a world of difference all the way to the patient after a huge life event like Billy experienced. And it's consultants like you, it's partners that we're all aware of, doubling down and being very intentional with that education piece across the revenue cycle, and providers buying into that. It's not a quick fix, but it's probably the right one long term. I appreciate you being here.
And it's fun. I mean, I love Billy Bob's. Got some good stories. Billy Bob.
Before we go, tell me your favorite story.
So one time I came with my mom. This was back probably 10, 15 years ago or so. And her friend, and my mom's friend is an interpreter, so she's professional. She signs professionally, right? And so my favorite bar trick for her is to get on the dance floor and, sign the lyrics to the rap songs. And they're playing the Get Low song, And she's probably 60, I guess, at this point. And she's getting low. She's signing. She's getting low. Well, she falls because they put the little sawdust or whatever on the floor, So feet come out. Woo! She's up. Feet in the air, everything, right? And then all these young guys come pick her up, and they're helping her up and everything. We got free drinks the rest of the night. It was a good time. We had a good time.
It's always a good time at Billy Bob's.
Good time at Billy Bob's, yeah. Standing on the stage, doing the line dancing and everything.
Wow.
I've done a few.
But it's a good time here, and we're thankful that they had us. I appreciate you sharing the importance of what we're doing in healthcare. And what we see in DFW is no coincidence. The population's growing, which means the patient population's growing, which means the providers are growing, which means they need more help, and that attracts the partners, the solutions, the innovation that we're seeing from, innovative, disruptive groups like Wildcatters and BioNTX and BioLabs, all the way up to the cornerstone institutions like Texas Health and Baylor Scott & White and Parkland and others. And so you play a huge role in this community and this ecosystem. Thank you for all you're doing, and I appreciate you being on stage with me here at Billy Bob's.
Yeah, it's been fun.